Good afternoon and happy spring. My name is Kathy Hickey and I'm the Information Specialist for Massachusetts Family Voices, a project at the Federation for Children with Special Needs. Welcome to Family Voices webinar on Children's Behavioral Health Initiative. We're so glad you're able to join us. I'd like to give you a little background on the Federation for those of you who are new to us. The Federation for Children with Special Needs started in 1974 by a group of parents who were part of a coalition that pushed to get the first special education law in the country passed. The Federation provides information, support, and training to families whose children have special needs, special health care needs, and children who are at risk culturally, linguistically, or economically. Helping families access and advocate for quality health care for their children with special needs is just one of the Federation's many projects. I will be facilitating the webinar today. This webinar will be recorded and archived at a later date on the Federation's website. A few technical pointers. Please be advised that everyone will be muted except our presenter. If you have any questions, please use the webinar toolbox that allows you to type in questions and we will answer them either during the presentation or I will collect them for the question and answer portion of this webinar, which will follow the presentation. Our webinar today will be presented by Emily Sherwood, the Director of Children's Behavioral Health Interagency Initiatives at the Executive Office of Health and Human Services. Welcome, Emily, and thank you to our IT Director, John Sullivan.
Thank you, Kathy. So thank you, everyone, for joining us today. And I have a number of slides to go through, and if you have a burning question, please type that in for Kathy, and she'll give it to me. And we'll also have time for questions at the end. So let's get started. Okay, so some of you may have heard of the Rosie D class action lawsuit. It was brought on behalf of a class, a group of children and youth on Mass Health who have a what's called, it's a legal definition, a serious emotional disturbance. And this case started back in 2001, went to trial in 2006. There was a final judgment issued by the court in July 2007. So Mass Health, and that is the Massachusetts state government Medicaid program, and just to be clear about that, Medicaid is a partnership between the state government and the federal government. So it was established by Congress. There are rules that the federal government sets out. We follow those rules, but states do have some choices of how to do things, and we pay for half in the state, and the federal government pays for half. So what this lawsuit was about was there was an addition to the Medicaid Act added, and it was kind of interesting. It was added after the Vietnam War, and the military found in the draft that there were many, many young men who had undiagnosed medical conditions and disabilities. And they realized that there were lots of young people not getting good medical care, frankly. So what Congress did was add a very strong entitlement to the Medicaid program that said that state Medicaid programs, if they were going to participate, must pay for well child visits for kids. And this goes back to a period, this is in the 60s, that not, like regular commercial insurance only paid for sick visits. They didn't pay for well child visits. So this was making it very clear that Medicaid programs had to pay for well child visits, and that during these well child visits they had to make sure that physicians screened for a whole host of different conditions to make sure that a child was growing at the right pace. There were vision checks, hearing checks, and part of it has always been assessing a child's social and emotional well-being. So the plaintiffs in the case, the lawyers for the group of young people, said that Massachusetts was not following the statute, the Early Periodic Screening, Diagnosis, and Treatment statute, when it came to mental health care. And what was very interesting and important about this case was that it has not ever been very clear what exactly the responsibility of the Medicaid program has been regarding mental health care. And just to say, if you think about a commercial insurance program, Medicaid is an insurance program. It's paid for by the government. mental health care in insurance has generally meant outpatient therapy and then hospitalization. And it's only been in the last 20 years that there's been some more flexibility, more flexible services, particularly for young people, of having, in our state we had something called family stabilization teams, and they were designed to help prevent hospitalization for kids who are experiencing an acute mental health crisis. It was also used to help kids come home from the hospital, but this was all organized around preventing hospitalization or shortening hospitalization. It wasn't really a long-term comprehensive service. So what the lawsuit was all about was saying that the state Medicaid program, Mass Health, under EPSDT, had a responsibility to pay for intensive home and community-based services for kids with significant mental health needs. So the lawsuit, the court determined that we were out of compliance. We were not following the law properly, and then what was negotiated was what's called the remedy, and that means the activities that the Mass Health program has had to do to come into compliance with the law. So here are the three major parts of the remedy. So there are 6, not so new now, we're now into our third year. So 6 new home and community-based services, and this is what we're going to spend the most of our time talking about today. Another really key part of the remedy, which is, I think, very, very important, is that I had mentioned the well child visit. Well, what this lawsuit says is that in Massachusetts, children and youth under the age of 21 who get their primary care through Mass Health, the primary care doctor or nurse has to offer to screen them during their well child visit for potential behavioral health conditions. And so some of you may have run into this where we have like 8 different tools. They're mostly short questionnaires that are filled out by a parent or by a young person in the waiting room. The physician or nurse goes over the answers, and they're not diagnostic. They're really just designed to pick up on issues such as depression or anxiety or whatever, and just indicate whether something needs a closer look. And that closer look can be the physician or nurse in that practice talking to the youth, talking to the family, maybe scheduling a follow-up visit. Or they may decide, the caregiver and the physician or nurse may decide together that it's worth a referral to a mental health clinician to just get a better sense of what's going on. Another part of the lawsuit was that the judge was concerned that depending on where a child goes for mental health services and whether kind of the presenting problem, for example, is a substance abuse issue, or maybe there's been trouble in school, that kids can be looked at sort of differently depending where they first touch the system. And so the important issue here was to make sure that every kid who's getting a mental health service through Mass Health has a standard comprehensive assessment, and we are using a tool that's used in a number of places around the country called the Child and Adolescent Needs and Strengths tool. So that is something that a mental health clinician uses, and I'll just say something. You can, if you have youth who are children who are using any of these services, you can help us on this. The way we train professionals to use this tool is they are not supposed to sit with you and go through it like a checklist. That's not the way to do it. What it is designed to do is be a guide for the clinician to have their usual conversation with you or your child when they're starting services. So it should be a very natural, relatively easy conversation about what brings you here and what is your child's strengths and what are the needs that are coming up, but it should not be done as a checklist because it's very tedious when it's done that way. So that's something we try and teach people, but we still hear people using it that way. Okay, so let me just talk about what CBHI is. As we talked about before, this lawsuit started a long time ago. It was at least 3 governors ago. And when a new governor is elected, one of the things they do is they cross out the old governor's name on all the lawsuits and they put your name in. So this was a lawsuit that Governor Patrick inherited. And our Secretary of Human Services at the time, Judy Ann Bigby, really saw the potential of what we could do with implementing the remedy in this lawsuit. So she purposely created a kind of a steering committee to oversee implementing the remedy of all the state agencies that serve children, even though the lawsuit was just telling the Mass Health Program what to do. And what was important about this is we were trying to make sure that the new system worked well with other services provided by other state agencies. So she created this thing called the Children's Behavioral Health Initiative. And you can see here, these are the values. I think none are probably surprising to any of you. Okay, I've actually already talked about this. This is the behavioral health screening. Just to say that our physicians and nurses in our state have just done an incredible job. They were very frustrated in the beginning because they only had about 3 months notice before they had to do it, and they're used to kind of driving what happens in their practice in their exam rooms, and so it's a little frustrating that a judge could tell them what to do. But we're really impressed that that sort of core period of kids 3 to 12, over 75% of youth who go for the well child visits are getting screened, and it's continuing to go up. Okay, and our what we're finding is about 8% of kids. The screen indicates there's possibly a behavioral health need. Again, it's not a diagnosis, but just there's something here we ought to look at more closely. And that's consistent with research that's been done using these various screening tools. Okay, we just talked about the CANs, so I'm just going to skip through this. Actually, let me mention one thing. We built a computer system to hold all the information from the CANs if the parent or guardian consents. And I just want to say it's the first time that Mass Health has actual information about the needs and progress that children and youth are making in these services. So although it does mean that pretty detailed information about your child and family can go into the system, I want to just put in a plug that it was built to extremely high security standards, and there are maybe it's under fewer than 8 people. It's like a couple of people on my staff, maybe a couple of IT people who actually see the name, and the identifying information. Otherwise, it is with most people working with this data, we're working with it in a de-identified way. So it's fabulous, and we're being able to look at how kids are doing in the services, what the differences are, with different conditions, different areas of the state, different ages, different providers. So it's really, really useful information that will help us improve services over time. Okay, so let's get to what I think everybody wants to hear about. So at the kind of the heart of these new services is something called intensive care coordination. And one of the things there's lots of research that shows is that kids, by their nature of being kids and being dependent on their parents and other systems, namely schools, meeting the needs of children is really complex and requires a tremendous amount of coordination between different parties and families that know that burden well. And the model of this model called wraparound, and there are a lot of different people who use the term wraparound. This is something, it's a very specific model of planning and implementing services. And I'll just tell you a very, very quick story about how it was sort of invented. It really goes back about 25 years, and at that time what was available for families whose kids had pretty significant mental health needs was really, again, outpatient therapy and hospitalization and residential treatment. And there was kind of a national scandal of the number of young people in residential treatment. Their outcomes were not good. They were often put into programs with other kids with significant needs, and sometimes they learned sort of more problematic behaviors from the other kids. And there was lots and lots of research showing that also, even if the program was good and they were making some progress in the program, when they came back to their community, it was hard to sustain those gains. So there was an interesting thing that happened. There were kind of two things at once. One, you had innovators, professionals in the field who felt what we were doing was not working, and they really wanted to do something different. And at the same time, you had the movement of parents getting politically organized and kind of pushing back on the mental health provider community, which had tended to view families as the source of their kids' problems in a pretty simplistic and harmful way. So you had two kind of movements of innovation happening at once, and wraparound is really what came out of it. So one of the examples, there's this group of men and women who are called kind of the grandmothers and grandfathers of wraparound. One was a guy named Carl Dennis in Chicago, working in the African American community in Chicago. Another guy that we have used for our trainer is a man named John Vandenberg, a psychologist he was living in Alaska at that time. Alaska had all this oil money, so they could just ship kids in trouble to residential treatment facilities in the lower 48. But the kids lost, really it disrupted their relationship with their families, with their peers, with their community, and it was, again, outcomes were not good. What John did, he started with 25 kids, and he created an extremely individualized plan for each child. And it was very entrepreneurial. It was things like he knew, fishing is big, commercial fishing is big in Alaska. He knew a bunch of guys who were fishermen, and he would recruit friends who were not afraid of acting out, teenage boys, for example, who would be willing to spend time with young people, after school, during the week. And they were good adult role models. They were teaching them about work that was very relevant to that culture in Alaska, and it was a way of connecting them into, age-appropriate, normal activities for that community, and, for kids that age. So it gives you, it's really thinking creatively, and one of the another very critical pieces, I'd say the hallmarks of it are really working in genuine partnership with families and recognizing the expertise of families as well as the expertise of clinicians. It was really a conscious effort to try and break the old patterns of, the clinician knowing best and understanding that clinicians did have expertise, but there was no one who knew the child better than the child's family and understood the culture of that family, and that information really needed to be used to come up with really good plans that would work for the kid and the family. Another hallmark is identifying what the family and the youth do well and what can be built on. And there's so many stories I've heard personally from families who've been in wraparound where they've said, nobody official or nobody in a program ever talked to me before about what I was doing right. They would talk to me about what I was doing wrong and needed to change, or what my child was doing wrong and needed to change. So building on strengths, extremely individualized services that really work for that kid and family. Those are really the hallmarks. I'm going to actually talk more about it. I always do this. On this slide, I talk all about wraparound, and there's a whole other slide on wraparound, so I'm going to stop there. Another critical service that is part of the wraparound model, and again, it sort of came up as part of this sort of family movement, was something called family partners. And they are typically mostly mothers, but some fathers, who have had children with various kinds of special needs. Usually their kids are now grown, so they have a little time and they can work outside the home. And they have, through their own experience, become fabulous advocates and extremely knowledgeable about the various systems that families have to interact with. So they just become great peer supports and coaches for families who are newly either there's a newly identified need for the kid, or are newly interacting with school systems and other state or public or private services. So the family partners are available for families whose child is enrolled in intensive care coordination, but also in-home therapy or outpatient therapy. So in-home therapy is therapeutic treatment that occurs in the home It can be more focused on the individual child, or it can be family therapy. It's particularly useful when a family is having a hard time making it into the office for office visits, or what really needs to happen is family therapy, or if there are just really some pretty extreme needs and the family really needs some folks in the house to help see what's going on, help understand what's going on, and help develop new ways of handling what the issues are. It consists of a therapist, but then also a paraprofessional who works under the supervision of the therapist. In-home behavioral services is kind of a specialty variant on that, a special service. It uses clinicians who are trained in behavioral approaches. Some are trained in applied behavioral analysis, some in other behavioral approaches, but they have to be able to do what's called a functional behavioral assessment. And it's really for kids. We just met with all these providers recently, and they're saying about, let's see if I get this right, about 75% of the kids they're seeing are kids on the autism spectrum, and about 50% of those youth have little or no language. So it's really a way of working with kids where a talk-based therapy is not going to work very well. Therapeutic mentors are non-clinicians. They work under the supervision of a clinician, and it's, I guess one way to start to say this is it's not just a big brother or big sister. So it's not just someone to hang out with a kid. If you have to think about, this is a Medicaid lawsuit. Medicaid is a medical program. All of our services have to be, by federal law, medically necessary. So what the therapeutic mentor does is there is a treatment plan that's done either by the outpatient clinician or the in-home therapist or the intensive care coordinator. And if there are specific social skill building activities that a kid needs, so help interacting with kids and adults, managing conflict, that this person can help that kid with skill building in real world situations. So the therapeutic mentor can come to school, to after school programs, can help kids sort of anticipate what are problems they run into, kind of rehearse things, be there to talk about it afterwards. So and we've been hearing really, really nice feedback that kids really like this. This makes more sense to them than therapy a lot of times. So there's been some good reports. Finally, mobile crisis intervention. And the Mass Health Program had an emergency services program before this, and it was really specifically about determining whether a kid met the criteria to go into the hospital when there was a crisis. This is a much broader service, and they by contract, all the mobile crisis providers need to come out to the home or school or wherever the kid is within an hour of being called. So it's not like calling an ambulance, but it is within an hour. Close to 90% of the time, they do come out within an hour. This is a big service. About 25,000 kids a year are seen. So there are lots of people who they don't come out within an hour, and so it's something we're continuing to work with the providers on. But the good thing about this service is they can stay involved with your family for up to 7 days. And so that can be, multiple visits to the home. It can also, they're very good at helping families either reconnect with a service they had before for their child, or refer and kind of do a warm handoff, make sure they're connected to a new service. And they do a very, very good job of that. Okay, so just back to the wraparound care coordination. So I just want to be a little more concrete now about what it is. So there is a care coordinator who is a mental health clinician. The majority are master's level, but there are also bachelor's level mental health clinicians. And they and the family partner work with the family to create a team. And one of the goals of the team is, if you are also working with your school department, for example, or if there's a youth who's, gotten in trouble with the law and there's a probation officer, or there's DMH or DDS, if there are basically multiple things to be coordinated. The first goal of the team is to have everybody on the same team, so everybody's hearing the same information, sharing their expertise. The family is a key part of the team, and a goal is actually, it's hard to do, but a goal is to have half of the people on the team not be professionals, but be people that the family has invited to be part of their team. So it can be friends, extended family, whoever. It's sometimes really great for adolescents to have, we've had a lot of different teams where they will have their best friend. And so they can be really thoughtful about how to problem solve. I mean, there have been some great stories about, kids who just have a really hard time getting up and going to school, and they get into a big fight with their parents about it, and just a real hassle. And a friend being a real key sort of participant who can say, okay, I'm going to come pick you up every day to take you to work. It's a simple example, but sometimes little things like that can really make a difference. And with having the non-professional, also it's another thing that helps sort of balance out the power between the professionals and the family, and it sort of helps make sure that the professionals are really looking at your family as its unique self and really understanding you and your family and your goals for your child. It's also a way to make sure that these teams are, culturally competent and sort of really understanding the family culture. So this service is delivered by 32 what we call them community service agencies across the state. We'll talk more about that, how you find out which one, etc. soon. So family partners, I've already talked about this. In-home therapy, this is just more detail you can have. It's really everything I've already talked about. You can have this as a resource. Let's see. Okay, so this is important. So one of the things that's always sort of interesting to develop a service system out of a lawsuit is you have all these lawyers talking about what the services should be. So we ended up with this list of 6 services. We were then able to have some really great national consultants help us think about how these services all connected to one another. So what we came up with was that at the center is a clinical service, and it is either outpatient therapy, in-home therapy, or intensive care coordination. You could have all 3 of these services if you did. The intensive care coordination would serve as they would do the care coordination, and the in-home therapy would be doing their clinical work, and then if the child was also doing outpatient therapy, they'd be doing their clinical work. You might also have in-home therapy and a young person also getting outpatient therapy. The in-home therapist would take care of care coordination. And so one of the things we'll get to in the next slide, so in each of these levels there is a clinician and they are doing a comprehensive assessment. And let me just go to the next thing. So you can see that it's really, so the good news and the bad news is, the good news is there's family choice about where to start. That can also be confusing. What are these services and what's the right fit? And I'll talk a little bit more about that in a minute. But families do decide, it's really a matter of deciding which of these 3 doors to go into. You can see that the emergency services one, you get that number, you can always call it. But the services that family partners, in-home behavioral, and therapeutic mentoring, we call them, they're hub dependent. So what that means is, in each of these services, there isn't a clinician doing a comprehensive assessment and treatment plan. So someone needs to do that. So these 3 services, family partners, in-home behavioral, and therapeutic mentoring, if you're going to have them, they have to be connected to one of these hub services where there is a clinician who will be doing a comprehensive assessment and a treatment plan. Okay, let me just go back for a second. All right, so in terms of deciding which door to start, if you had a child who had never had any mental health treatment at all, you would probably start with outpatient because you want to learn more about what's going on. Unless there's something there's really a lot of crisis in the home that's happening pretty regularly, things are pretty hot, then you might say, well, forget that, I'm going to start with in-home therapy. I need sort of hands-on help soon. If there were no other services from other agencies, they would probably in-home therapy or outpatient therapy would be fine. Or if, say, you had there's an IEP or a 504 plan, but it's an appropriate plan, you're happy with it, it's stable, then again, outpatient therapy or in-home therapy. But once the thing to think about for intensive care coordination is, one, if there are lots of people to organize, so there's multiple state agencies or service providers, so you need help with care coordination. Or two, if there's a sense that what's going on with your child is not really well understood. So if there's a lot of complexity and you don't really feel like anybody's got a really good answer, the intensive care coordination team can be very good for that, of having kind of multiple perspectives, bringing in people onto the team, or consultation from particular professionals who that information will be shared with the team. It can be a really, really good way to get kind of that richer look at what's going on, and often a clearer understanding and diagnosis coming out of that. Okay, so to get the services, so you have to have Mass Health eligibility, and there are lots of different kinds of Mass Health, and then you have to have either standard or common health. And we'll talk a little bit more about how to apply for that in a minute. And your child has to, the services have to be, in our language it's called, services have to be medically necessary. And we leave that to the providers. So you basically pick a place to start. So you start with one of the hub that makes the most sense to you, and as they do the assessment and talk to you, they will tell you, yeah, this is exactly right, we can definitely help you. Or they might say, say you went in for outpatient and they think something else is needed, they may recommend that you go to in-home therapy or intensive care coordination. So they will sort of help suss that out with you. And so to start, it's a matter of deciding which clinical hub to start with, and then to contact a local provider of the service. Now, information on that, I've got some resources at the end of the slide deck, and there's our website, which is, it's on here, but it's mass.gov/masshealth/CBHI. We have brochures you can download. They are set up by region. There are 5 regional versions, and they list the names and telephone numbers of all the intensive care coordination providers and in-home therapy providers and mobile crisis providers in your region. There are too many outpatient providers to list in the brochure, so what we recommend you do with that is call your child's managed care company. And for those of you who have Common Health as secondary insurance, that's going to be the Massachusetts Behavioral Health Partnership, and they all have customer service lines. It should be on the insurance card you have, and you call them and you say, I'm looking for outpatient therapy for my kid, and they will ask you a series of questions and help you find someone in your area. There's also another website that has the address is on that last slide, and you can put your zip code in, and it has on that, it has intensive care coordination, in-home therapy, also lists providers of therapeutic mentoring, in-home behavioral, family, and mobile crisis. Family partners they all work for one of the community service agencies who also deliver ICC, but the other services may be provided by other folks. Okay, so Kathy's the expert at helping people apply for Mass Health, so you can always call the Federation for help, but you can get started on the website here. You can call a Mass Health Enrollment Center, and what you're going to need to do is fill out a medical benefit request, an MBR. And what you might want to do on our website here down at the bottom of this slide, we've done a tip sheet about just some tips on applying for Mass Health, and I'll just tell you, we were certain we could do something useful that would be a page long, and we spent months and months on it, and I think it's 3 or 4 pages. So that is the world. Okay, now as people know, to be on Mass Health standard, there is an income limit. And in our state, we have a program called Common Health that is for young people and adults who have disabilities. And if you meet the disability criteria, there is no income limit. So you could be a millionaire and get on Common Health. There is a sliding fee premium scale, and some families find that pretty challenging. The price is pretty high, so you have to weigh. What happens is there's no harm in applying, there's no obligation in applying. You apply and you will get a letter and it will say what your premium will be, and then you decide whether you want to enroll. And if you are thinking about applying for Common Health, please do download the tip sheet, because we give you some steps of how to combine your do one application that does your MBR and also gets going on the disability supplement right away. So it just cuts out a couple of steps. So the details of that are on that tip sheet. So getting Mass Health standard or Common Health is the first thing one has to do in order to access remedy services. And one thing I want to be clear about, we called them CBHI. They're new services. We also really, really want to signal that there's a real values base to these services. They are about partnership with families. They're about individualized care. But we've confused people. They think they're separate from other Medicaid services. These new 6 services are just additions to the mental health services provided by Mass Health. So they are just a Mass Health service. It's not a different program. It just has had this different label because of its unusual start in a lawsuit. And also, again, we're conveying a certain shift in approach in delivering these services. Okay, so we've already gone over this. Okay, one thing to mention is that if your child does not meet the disability criteria, and for income reasons you're not eligible for Mass Health Standard, you may be eligible for Mass Health Family Assistance, and some young people are, older teens can be eligible for something called Mass Health Essential. And those services we're only able to cover, with that coverage, we are only able to cover mobile crisis intervention and in-home therapy. We had hoped when the lawsuit just covers standard and Common Health. When we started, we really wanted to cover every kind of Mass Health with all 6 of the services, make them available. And then when the recession hit, we really were not able to do that. Okay, so part of the lawsuit, this is a lawsuit thing. The lawsuit was for young people who met one of 2 definitions of serious emotional disturbance. Now, the only place these definitions are relevant is intensive care coordination. That is the only service. None of the other services does this matter. For intensive care coordination, the way to really boil this down is that there must be a mental health diagnosis. So you could have a young person who also has an autism spectrum diagnosis. It can even be the primary diagnosis. There just must be, to access intensive care coordination, there must be, in addition, a mental health diagnosis. Now, the other parts of the definition of serious emotional disturbance are that, it's a significant condition. It is expected to last a year or more, and that it impacts your child's functioning. Let me just look back at the previous one. Functional impairments with which substantially interferes with or limits the child's role or functioning in family, school, or community activities. Okay, so, we've already talked about this, about picking the hub. just see. Okay. So this is some good advice that if you have some kind of mental health provider, but you're feeling like things are just not where you want them to be for your child, definitely a good place to start is talking to your child's therapist about, and you could even download the brochure, bring that in. Not all outpatient therapists know about all the new services, and in the brochure there's a description of each of the services, and so that's something you could use. You can also talk to your pediatrician, bring the brochure and talk to the pediatrician and get their perspective on things. Okay, so here's the website. It's the Massachusetts Behavioral Health Access website, and if you go to that link, it'll tell you how to log on, and it's clear. You just put your zip code in, and it'll show you nearby providers. And then, as always, you can always call your child's health plan's customer service center for help finding the right service. Also, I want to say this is something people don't think of. They can help you if you're having trouble with access. If somebody is saying there's a waiting list or you're just running into some kind of snafu, you can always call your child's health plan's customer service center for help, and they can sometimes, they do often, really clear things up for families and help people get into services. So it's a good resource. Okay. This is worth talking about. So you contact the provider of the service you're interested in. They will schedule an appointment. Now, as I said, they are the ones who, they know what we have things called medical necessity criteria. They're actually on our website. They're quite broad, which means they're designed to be inclusive and get as many kids into service as possible. But, conceivably there could be a time when a provider might say, I don't think this is the right match of a service for your child's needs. If you don't agree, ask to speak to their supervisor. Or you could go to see another provider nearby, and again, you could call your health plan customer service center for help. So if you run into any problems with access. And I think I'm going to just stop now. The rest is just some information for your interest of number of kids who've been served and some quality indicators. But let's just take some questions at this point. Right now we do not have questions. We do have one reminder. Hold on one second.
Okay, we don't have questions right now, but we do have one reminder that once you're approved for Mass Health and you get your premium bill, if you decide you do not want to keep the Mass Health coverage, you need to cancel the policy by calling the member enrollment center or putting it in writing to them. Otherwise, you will be expected to pay that monthly premium.
Thank you for that clarification. Good.
Also, one question that I have is, how do you find the hub that will service your area? How do you know what managed care provider to use?
Okay, so that the managed care provider is not the hub. So let's not talk about hubs yet. Let's just talk about the managed care provider. So when you enroll in Mass Health, so the first step is getting clear that you are eligible for Mass Health. And once that has happened, you are sent an enrollment packet, and that will give you information on who covers your service area, which of the managed care plans. Now, several of them are statewide, so the Massachusetts Behavioral Health Partnership is statewide. I think Boston Medical Center HealthNet is now statewide. So you will have that information in your enrollment packet. And if there's a question, you can call the Mass Health customer service line. Okay. And are all different languages available at all of these sites? Yes and no. So yes, they need to be. What we do find is for folks who need Spanish language clinicians, there sometimes can be a wait. We see longer waits for that than for English, so that can happen. Okay. This webinar will be available on the Federation websites and will be archived. So if you did not catch it all, you can
come back to our website and join us again. Thank you.
Thank you, everyone.